Uh, Everyone, welcome to NASEMSO 2020 Reimagined. We're very appreciative of the folks that were able to join us today. I'm going to pause to introduce our president, Kyle Thornton, for a few opening remarks.
Good morning, everybody. Welcome to NASEMSO Reimagined 2020. I'm sorry that we can't be together, of course. I don't know about y'all, but I'm tired of COVID and I'm tired of the word unprecedented and all of those things. But it certainly has been an interesting year. So I appreciate you taking time out of your schedule this week to join us as much as you can. And I think that Kathy and the rest of the NASEMSO staff has done an absolute amazing job in putting this all together and having a opportunity for us to be together at least virtually. So certainly my appreciation to them and all of our gratitude for getting this done. We are very lucky to have an opening session this morning of, from our Surgeon General, and I'm going to go ahead and introduce that because unfortunately I have to leave. I have another commitment that has popped up regarding COVID, but I'll go ahead and introduce our morning presentation, and then I will say goodbye for a while, and then I hope I'll get the chance to see you later. Kathy, is that okay to go ahead and introduce the Surgeon General?
Patients, their families, and your...
Sorry, Kyle. I'm sorry that presentation got ahead of you a little bit there.
So is it okay to, I take it it's okay to go ahead and introduce him?
Yep.
All right. Well, our first speaker is Vice Admiral Jerome Adams. He is the Surgeon General of the United States. He is the former health commissioner for the state of Indiana, and thereby no stranger to the challenges faced by EMS offices all around the country. He is a former anesthesiologist, so he's keenly aware of the problems associated with the opioid epidemic and other issues that we deal with on a daily basis. He was the first Surgeon General in about 13 years to issue a Surgeon General's advisory urging more Americans to carry naloxone for the, as you guys all know, the reversal of an opioid overdose. So he's been very involved with EMS and pre-hospital issues. His initiatives in Indiana have related to needle exchange programs, the state's response to the Zika virus back a few years ago when we thought that was kind of a bad, scary thing, and it was, but everything's been trumped now. So I think it'll be very nice to hear his message this morning. Again, I'm sorry I don't get to enjoy it myself, but enjoy the rest of the meeting. Enjoy this message, and it is now my honor to express our gratitude for Surgeon General Jerome Adams' work to support the nation's response to all the public health emergencies, and it's my pleasure to introduce his message this morning.
Thank you, Kyle.
I'm United States Surgeon General Jerome Adams, and I want to start by thanking all of you for the work you've done on behalf of patients, their families, and your communities during this particularly challenging time. SARS-CoV-2 has shaken the world to its core, and we've struggled over the past year in a race to protect human life from a novel and deadly adversary. While your jobs were already challenging before COVID-19, the requirements for donning and doffing of PPE and the risks you and your teams encounter constantly have magnified stress levels beyond measure. But your skills and experience, your dedication and stamina, your commitment to excellence have saved lives and helped people return safely to their families. This pandemic has hit us all hard and has particularly impacted people of color, people with underlying conditions, and those who are older. This virus has highlighted a multitude of factors rooted in pre-existing medical, but also pre-existing social conditions that have conspired to reduce our resilience, our opportunity, and our health. You see, when we think of the pandemic, most of us immediately think of health care. But as critical as healthcare is, we know that health really begins at home. It begins in communities designed to provide income and financial security, education, and access to transportation. And healthy communities must be free of structural and institutional barriers related to race and bias. In a vicious cycle, the social determinants, these things like transportation, childcare, and housing, contribute to medical determinants, chronic diseases such as diabetes, lung disease, and high blood pressure. And it should be no surprise that these diseases are especially common in communities of color. The social determinants make individuals more susceptible to infection with COVID-19, while the medical conditions are associated with more severe COVID complications and more deaths. For example, we know that social distancing and teleworking are critical to preventing spread of coronavirus. Yet only 1 in 5 African Americans and 1 in 6 Hispanic Americans have a job that allows them to work from home. People of color are more likely to live in densely packed urban areas and in multi-generational homes, making it harder for them to isolate or quarantine if they've been diagnosed with or exposed to the virus. And while we, as the US government, have acknowledged and begun to work to prevent these disparities and terrible outcomes, we know there is much work yet to be done. There have tragically been more than 200,000 fatalities due to COVID-19 and over 7 million American cases diagnosed, including our president. This should show us that everyone is vulnerable and we all have to do all that we can to stop the spread of this virus. We're making rapid progress in the development of safe and effective vaccines, but I need your help now to combat vaccine hesitancy so that when these life-saving vaccines are ready, we can protect all Americans against COVID-19. In the meantime, we can protect millions from the flu, measles, and other vaccine-preventable diseases. That's why it's critical we increase patient comfort with the concept and practice of vaccination, which can start by asking each and every person that shows up in your ambulance or ER if they've received their annual flu vaccine. The more we can get folks accustomed to getting their flu vaccine and give them an opportunity to talk about their concerns with health providers, the more success we'll have with a future COVID-19 vaccine. While we are optimistic about a vaccine, I do want you to remember there are other simple measures you can take to lower spread and move towards safe reopening. Our best immediate defense against this infection are what I like to call the 3 W's. Wash your hands, watch your distance, meaning maintain at least 6 feet from others and avoid crowded indoor spaces, and wear a face mask. And again, it's imperative that everyone gets their flu shot this year. The fact is, while advances in testing and treatment are critical, the way we ultimately defeat this virus for good is through individual health behaviors, simple acts that will help us flatten the curve, decrease the spread of COVID-19, and allow us to safely reopen. On this note, I've launched a messaging campaign called #COVIDStopsWithMe that you can check out on Twitter at @surgeon_general. These are unprecedented times. Again, we've all been deeply affected by the pandemic. Just as our country has carried on through other tumultuous and uncertain times, we will do so once again. I'm confident we can not just defeat COVID, but come out the other side stronger. And it will be in no small part due to your compassionate work. So to all of you gathered virtually today, take a deep breath, stay committed to your mission, and know that together we will get through this.
Hi, everyone. Kathy Robinson here from NASEMSO headquarters. We have several sessions scheduled for you this week to try to minimize the burden on your time, knowing that everyone has very various work obligations they need to attend to. You've probably noticed in messaging we are recording the sessions, and the reason for that is because we know that people will have to come and go and they really don't want to miss anything. So we've tried to highlight some opportunities for you in learning, and are just very appreciative of the fact that you are able to join us today. I really want to take a moment to thank our generous sponsor, FirstNet, built with AT&T, that has made the recording and the presentations possible. They will be joining us this afternoon for an update that I know you won't want to miss because I have seen a preview of it. So hopefully you'll come back at 3 o'clock. But for now, we're going to proceed with our opening session, and I'm going to turn the meeting over to our Executive Director, Dia Gaynor. Dia.
Thanks, Kathy, and welcome everyone. Delighted to be here, although I'd much rather be together in person and miss all the opportunities that we generally have when we gather for our annual meeting and regional meetings as well. I already miss those madly. I'm going to go over some of the projects we have in the works, and following that, we'll do a little retrospective review of some major projects we just concluded, and also want Kathy to talk about our project on fatigue. So Hannah, I can just say advance the slide if that works the best, and we'll dive right in. Beginning with and I'm just checking whether I have control or not here. I'm kind of, no, Hannah, you've got control.
Okay, one sec. Sorry, I think my screen just paused. It just has a slight delay.
No worries. And the first slide is on our partnership with the EMS for Children Innovation and Improvement Center. And I'll turn the floor over to Rachel Alter to talk about that. Rachel? Well, in case she's facing some audio challenges, we can just go on to the next slide and jump back to this one once Rachel's established her audio. We're very excited about two new partnerships that we've established this year, namely because I don't know that we've ever had formal contractual relationships with the Association of State and Territorial Health Officials and the National Association of City and County Health Officials in the past. And separately and independently, they both sought our assistance. They were provoked by some resources that the CDC made available. In the case of ASTHO, to look at out-of-hospital promising practices related to post-opioid overdose incidents. And we've been assisting them by really taking the strength of our membership, who are knowledgeable about either statewide initiatives related to opioid overdose response, or to be knowledgeable about the existence of local programs. Mary Hedges has been doing the heavy lifting with this. It's a little memorable because it's the last in-person meeting that I attended back in March with ASTHO and CDC leadership, where several state EMS directors were present in person or virtually, and are assisting ASTHO to learn more about how EMS is contributing to this epidemic. In the case of NACHO, Kevin McGinnis has been assisting us heavily with the identification of community level, whether they're community paramedic or not, mobile integrated health type applications related to falls prevention. NACHO has a special interest in this issue, and we're assisting them with understanding how public health and EMS can work together on a community level to identify at-risk persons and assist with falls prevention. Both of these projects end at the end of this calendar year, but we're optimistic that there will be some carry-on work moving forward. And of course, all of our members can look forward to seeing the products of this work later this year or early next. Next slide. The pain management evidence-based guideline project is well underway. We thank the National Highway Traffic Safety Administration for making these resources available. This is a technical expert panel-driven EBG development process that we first exercised and improved when we did the naloxone administration EBG. So we're repeating that successful formula. In this case, we're also doing the framework for performance measures as well as training materials. Like the naloxone EBG, we'll also be preparing and submitting a manuscript for publication in a peer-reviewed scientific journal. This work will continue through November of next year, and the project manager is Mary Hedges, and you can reach out to her if you're interested in more details about that project. Next slide. So knowing that we don't have evidence-based guidelines for every condition that EMS personnel encounter, there may not be enough even evidence to create an evidence-based guideline for some of those conditions. We're continuing the process of maintaining model clinical guidelines, and this is again thanks to NHTSA and HRSA's EMS for Children program to revise the model clinical guidelines that were last published in 2017. This also utilizes not only a technical expert panel, but separate subject matter expert reviewers who will zero in on their area of expertise to make sure that the guidelines are as contemporary and clinically appropriate as possible. Something new in this year's revision is that we will be utilizing an expert technical writer to create a style guide and conventions manual. This will assist us in standardizing the format of the guidelines, not only upon publication, but upon submission, so that when an interested party wants to contribute content, that they do so in a standardized manner to make the guidelines revision process more streamlined. This project will run through February of 2022, and the project manager is Andy Guinap, and our technical writer is Elisa Williams. Next slide. Our workforce guidelines project is the first of 3 cooperative agreements under our umbrella agreement with NHTSA. We have done, NASEMSO has done a fairly admirable amount of work related to workforce measurement, beginning with an effort to create 10 basic measures or calculation methodologies back in the early 2010s. This project will build on those basic measurement methods, and through June of 2023, we'll look a little harder not only at those measurement methods, but also to take advantage of states that have implemented methods of quantifying attrition, turnover, reasons for departure from the field, and hopefully establish something of a core standard for states to utilize that are interested in measuring and understanding workforce phenomena in their states. This project centers on a partnership with the National Association of State Workforce Agencies. We're hoping that they can turn into advocates who can assist their respective state EMS director and state EMS officials with workforce related issues. And that project manager is Jim Deteen. Next slide. And then our third cooperative agreement under our umbrella agreement with NHTSA is on state EMS specific system strategic planning. We had previously developed a resource, tools, and process to be used by a state EMS office. It was piloted successfully in Mississippi. And this project is to deploy it forward with 3 state EMS offices. So you can look forward to an invitation to consider whether your state would be interested in trying this process out. It yields a state-specific EMS strategic plan. We are still in the process of identifying the project management team for this, and this cooperative agreement runs through March of 2022. Next slide. We're also very excited to have a new relationship with FEMA, specifically the U.S. Fire Administration. In 2009, they published a document called Information for First Responders on Maintaining Operational Capabilities During a Pandemic. Internally, they did an ad hoc revision early in the COVID-19 pandemic, but what they've asked us to do via this project is to look at the state level statutory, regulatory, waiver, administrative policy actions that states took related to continuity of operations and responder safety, and effectively catalog those and create state-specific guidance about the kinds of tools and resources that, if not already in place, could be a consideration for this or future pandemics. Mel House has joined us as the project manager for this effort, and that work concludes in March of 2022. Next slide. And then finally, we have a new partner in the form of a large nonprofit corporation called the Center for Health and Justice. And this nonprofit works historically almost exclusively with the law enforcement world, namely the U.S. Department of Justice. And they've expanded their interest and their footprint more broadly to include EMS and other types of organizations that would find themselves on the scene with primarily overdoses, but also other social concerns such as housing and other resource shortcomings that communities may be experiencing. And their focus with us on the first year is to identify communities where diversion or the transport of persons who survive an overdose are taken to facilities other than emergency departments. And they use the word diversion to mean keep them out of the legal system and keep them in a healthcare, albeit not necessarily a hospital pathway. And they're also very interested in ODMAP and promotion of that, because the Department of Justice is heavily focused on ODMAP. And what we've volunteered to do under this project is to help find that connection between NASEMSO and ODMAP. We've found 2 states so far who have cracked that nut, and we hope to take advantage of their experience and expertise in how exactly that happened and what it takes to make that kind of automatic population of ODMAP possible from NASEMSO sources. I'm presently leading this project while it is expected to conclude in September of 2021. Like the ASTHO and NACHO projects, I certainly hope that we have carried forward work that continues at that time. And I don't know if Rachel's audio has returned. I believe that's my last slide. And perhaps we can page back to talk about EIIC.
Yeah, thanks, Dia. I'm here now. Technical difficulties. So just real briefly on the EIIC, this is our 5th year partnering with the EMSC Innovation and Improvement Center. Years 1 through 4 were with Baylor College of Medicine, and now our contract is with Yale. So specifically, NASEMSO is partnering with them in both the state partnership domain and the pre-hospital domain. And as it relates to the state partnership domain, we're working on onboarding materials for new EMSC state partnership program managers. So There's job descriptions that we're working on updating, as well as a toolkit that used to be a part of what was called the Rainbow Series that HRSA had created, and we're working on creating a more of an online updated toolkit to help program managers with their job and working on the state partnership grant. As it relates to pre-hospital domain, the biggest project right now is the pre-hospital pediatric readiness project. And many of you probably know about the hospital side of pediatric readiness. And now we're working towards a pre-hospital Peds Ready project with the steering committee that was formed in the fall of last year. Our charter was finalized earlier this year, and that steering committee is full of both federal and national partners, all with an interest in EMS and pediatrics. So right now we have just last month finalized a pilot of a checklist for EMS agencies, and we'll have a full rollout of that checklist later this fall. And along with that checklist, there'll be a toolkit, an online toolkit on the EIIC site to help agencies meet all the goals that are in that checklist. And it'll be followed up in 2023 of a national assessment of all EMS agencies across the country. And one thing I did fail to get on this slide is an upcoming telehealth collaborative. Currently, that is open for application. And the mission of this collaborative is to evaluate the impact of public health crises on children and youth with special health care needs and behavioral health emergencies. We're looking to assess telehealth capacities and provide guidance and support to improve access to the emergency pediatric services, particularly in rural, tribal, and territorial areas. So that application process closes at the end of the month, and we'll be selecting between 4 to, I think, about 15 states, depending on how many applications are received. And that collaborative will run from January 2021 through June. So if you have any questions about anything happening within the EMSC world, please feel free to reach out to me. Thanks, Dia.
Thank you, Rachel. And Kathy, I suspect you'll do a fatigue update, but that concludes our other projects in process report.
Absolutely. Let me just get my slide up here. I'm actually going to, what I'm going to do is redirect you to the fatigue in EMS homepage. Let me just, I'm not able to show my screen, Hannah. Thank you. So this is a project that has been ongoing for several years with our colleagues at the National Highway Traffic Safety Administration. We're subcontracted to the University of Pittsburgh School of Medicine and the Institutes of Behavioral Research to develop the fatigue risk management guidelines. And I think that we've been talking about this long enough that hopefully folks are familiar that the EBGs were disseminated in 2018. They were published as a special supplement to pre-hospital emergency care. And I'm going to click on that page in just a second to show you from our website how to access those documents. So phase 1 is complete. We're currently in phase 2. Those of you that are in state EMS offices have been receiving messages from us because we're in the midst of our experimental study that actually was supposed to start at the beginning of the year and got delayed largely due to the pandemic and EMS agencies just not able to participate at that time. We currently have a little more than 50% of our target enrolled and have started to collect data. This is the, we just announced the last chance for EMS agencies to participate in the study, so that is being coordinated by the University of Pittsburgh, and things are going pretty well at the moment. So if you go to our website at emsfatigue.org, you're seeing the project graphic on the screen right now, but if you go right down here and click on documents and resources, the entire supplement is there. The learning objectives that are being evaluated through the experimental study. We've mentioned in the past that there are 10 learning modules. Study participants view the modules, and their level of fatigue is measured before and after the education. And we should have the results of that study next year. That will progress into a online, web-based tool for folks to plug in their own schedules and determine their risk of experiencing fatigue, and perhaps work with employers to modify work schedules. So we really do have a lot of resources there. The implementation guide related to the 5 evidence-based guidelines that we disseminated, and lots of information. We continue to get really a lot of interest in these documents, and folks asking us questions on how to access the learning and the guidebook, all those things that were related to the project. At the when the study is completed, the 10 learning modules will be disseminated and available to anyone that wishes to view them, and we'll be able to provide those to everyone for free at the conclusion of the project. And if you have any questions related to the study, to the web-based tool, to the evidence-based guidelines, or if you're having any trouble at all accessing our resources, please feel free to email me at robinson@nasemso.org, and I'm happy to get you whatever information that you might need to assist your efforts. Thanks, Dia. Back to you.
I think the floor is Kevin's for a recap of the National EMS Assessment next. You may be muted, Kevin.
If anyone wishes to ask a question of the presenters, you can actually put that in the chat box or raise your hand. We are monitoring for those sorts of opportunities. Kevin, go ahead and try again. I think there we go.
I think we're all set on this. Can I get the first slide up?
Yes. Let's see.
Thank you, Hannah. That's great.
Yeah.
All right.
Okay.
Well, hello to everybody, and I also want to thank FirstNet, built by AT&T, having been a worker on that project for some 15 years, and a member of the FirstNet.gov board for 6 years. It's a great project, and I encourage people to learn more about it. But today my subject and hat are different. A project that I was pleased to assist with over the last couple of years that actually came out of work done in 2010, 2009 through 2011 that produced a national EMS assessment. It was conducted by the University of North Carolina and MSPIC. At the time, it was a massive undertaking. Those who have been in EMS offices for 10 years or more will remember the effort, because somebody in the EMS office ended up with a brand new iPad, first generation, back when it was a novelty, as a reward for turning in whole bunch of information about the EMS system in their states. This time around, we endeavored to, with our partners at NHTSA, to take a slice of that information in a somewhat more modest endeavor, and be able to update what we know about about EMS and its character around the country 10 years later. And so this was to produce the 2020 National EMS Assessment, and that's what we have today. And it was largely conducted through a survey of state EMS offices. We did check some other sources as well of data, but like the 2011 assessment, this primarily was a result of what came out of state EMS offices on their own state EMS systems. And so what I'm going to do in the next few minutes is simply give you a taste of what's in that document, a description of some of the offerings that there are and some of the findings. I'm not going to go into detail in the slides themselves for the most part. There's some that are pretty interesting, but you can go online on our website and download that. And Kathy has nicely put that up in the version of that in the handouts as well. It's a PDF version of the EMS assessment. Next slide, please. We started off, we asked questions in a bunch of different areas, from agencies to professionals to things like communications and education and medical oversight. So they're broken down by areas within that we normally look at in EMS. The first, EMS agencies, I would just backstep for a second and say that the results of the survey that we did were actually very good. We got 54 out of 56 states and territories to respond to the survey. Not all states or territories were able to respond to every question with data, because some they simply didn't have data for, but for the most part, with the exception of Samoa and Puerto Rico, these are fairly representative data. We found some 23,000 licensed EMS agencies were reported out of the 54 states and territories. Next slide, please. The primary types of agencies that we found in terms of ambulances and first response vehicles, ground specialty care service, and air medical services total to about 20,000 of those. And you can see the breakdown in other areas as well. Next slide, please. When we endeavored to try and categorize licensed agencies by level of care provided or level of licensure, from EMR through paramedic and levels above or addition to paramedic, we did consistently find another 20,000 agencies. So we know the numbers are at least in the right ballpark. Not all agencies were able to license by level or type of care. There were some 16% of the agencies were not able to be characterized that way, and the rest are as you see them. Next slide, please. Then we looked at vehicles, how many vehicles are operating of various varieties in EMS. We found 54,000 ambulance type vehicles out there, some 1,500 rotor wing aircraft, another 700 fixed wing aircraft, and then all sorts of vehicles in the area of first response vehicles, which are kind of hard to pin down because in some, for instance, fire departments, every vehicle is a EMS first response vehicle or categorized that way. And in some agencies, they are categorized differently. Next slide, please. We turn to professionals. We see that we have in all categories, including dispatch, some million licensed EMS professionals. We look in the areas of traditional licensure, we're seeing obviously somewhat less than that, but still hovering up around that million mark. Next slide, please. And we still have, many moons later, a variety of ways of licensing at levels that have hung around for a long time, largely in the between EMT and paramedic category, with a variety of intermediate I-85, I-99, cardiac, and other types of license levels that hang around. Many of them have been grandfathered, so that they're not licensing new folks under those, but they do still exist. Next slide. We did look at also age, gender, race profiles for licensees, and many states we found, particularly in the latter, do not categorize folks that way. So there's not a ton of information. You won't find any particular characteristics about us EMS types out in the field, other than that we mostly are somewhere in the neighborhood of 20 to 50, and in age, we're mostly white and mostly male. You'll see that there are a dose of folks in the above 70, above 80, and above 89-year-old categories, and we haven't had a chance to do any kind of correlation, but one would guess that one might see a bunch of those in rural states with volunteer services for the most part. Next slide, please. These are just, the next slide is just numbers on race and gender. We did have one territory in which the population of EMS providers were 70% female. And that was a single department territory. Next slide, please. One thing that fascinates me, people know that I have an interest in public safety communications. So we've looked at things like, are people able to do telehealth video? Now, mind you, this is a pre-COVID snapshot, and it will be interesting to see post-COVID where we get. But even so, where I sort of expect to see almost nobody doing telehealth video, we did find states that had at least a few agencies, 20% or so of states, doing some form of telehealth video. Not a whole lot, but at least there's a smattering out there in about a fifth of the states. The ability to receive a patient history on the scene for the medic with the patient at the time in real time goes back almost 15 years now to Indianapolis. Was the first I knew able to download from a health information exchange that kind of data. And today, again, we're looking at some 30 states that have some capability to download data on the scene. As far as being able to send information to the hospital ahead of arrival, that's even more. Some 35 to 40% of the states have some activity in that. Some have almost half their services able to do that now. And certainly with the capabilities that we know of that are out there being sold now, the applications that are out there to make that process more efficient, packaging telemetry data and video and voice and written data in a bolus of data to the hospital. That's going to expand greatly, especially with the COVID impact and also ET3 on our doorstep. Next slide. We looked at all of the types of responses, some 43 million of them, and a large slice of 6 million. We didn't know what kind of responses those were, but they show 28 million ambulance responses, another subcategory of first responder responses, and then it goes on down to ground specialty, interfacility transports, and air medical service responses. So we do have data on that. Next slide, please. We did ask about the numbers of transports done, and I would say that it says 30 million, some 31 million transports were recorded, not all states, and the reason we list the states here is because there are a handsome slice of states that don't record what kind of transport numbers they have. But one thing that is interesting is the number of, they've seen the emergency department of some 16 million transports, but from scene destination to other than the ED is already at almost 2 million transports. And with ET3 giving some influence in what we do, that's no doubt going to increase, and with COVID's impact of not transporting patients as well. Next slide. We looked at how states acquire their run record data. In particular, this particular look was simply, do you require run record reporting, EPCR reporting? Do you enforce that? Do you encourage it? And that sort of thing. And largely when it comes to ambulance services, by and large, they're required and enforced to receive data. And then it goes on from there, depending on type of service and state you're in. Next slide, please. We looked at how soon states require EPCR data to be turned in, and this has become really quite aggressive from the time when I was a state EMS director many moons ago. We have a number of states, 20 states, requiring data be turned in within 24 hours. And there are subsets in that group that are much more aggressive within lesser hours. Within 3 days or a week or 30 days adds quite a bit to that. So just fairly interesting how aggressive we are, and also obviously contributes to the ability to do real-time surveillance and that sort of thing. Next slide, please. %61% of the states submit data to one place or another to allow surveillance of public health outbreaks or terrorism. Next slide, please. And this is really impossible to see, but just to know that there is information in there on the number of states receiving federal sources of funding, as well as varieties of state sources of funding and how those break down. Next slide, please. We asked about participation in various federal emergency preparedness programs, and so we do have data on those that are participated in, and again, it'll be interesting to see post-COVID how this compares, because there will probably be an expansion of those programs, and perhaps an expansion of participation. Next slide. It's getting down to the very end, and we found that in 2018 and 2019, 85% of state EMS offices participated in one way or another in either real events or drills in emergency preparedness types of events or exercises. Next. And that would be the end of that. I would turn it back over to Kathy or Dia.
Thank you, Kevin. Kathy, specialty systems of care, I think, remains.
Yes, thank you very much. Are you, let me just make sure that you're seeing my screen. Here we go. Yes, thank you very much. Appreciate the opportunity to cover what we learned in the evaluation of specialty systems of care across the states. This has been a very interesting project that we couldn't have completed without our partners at the National Highway Traffic Safety Administration. I don't think that you'll find a whole lot of surprises. And as Kevin mentioned, we did upload these reports to the webinar, so you're able to download them. They're also all available on our websites and hopefully you find them useful. We actually started talking about the emerging systems of care in 2018 within the Specialty Systems of Care Committee. And the first question that we asked folks at that particular time was, what was an emerging system of care? And obviously we got quite a few responses to that. Nobody really being able to get their head around what it was that we were talking about. When we started the study, we realized that we quickly needed to focus because there was just too much information to try to compile with all those things that you see on the screen there. So what we found to be a little bit challenging was reaching the state systems manager when they were not physically located within the Office of EMS at the state level. Many of them were located in state health departments, but finding them and finding their contact information wasn't always the easiest thing to do. After all these years, and I know many of you have been involved in EMS for a number of years and in NASEMSO for a number of years, just trying to establish the baseline for definition, it was a little bit challenging because folks have different definitions in rules and regulations and understanding. So making sure that we're all on the same page in that regard. We also had a little bit of a challenge with the way people interpreted questions. And I didn't ask Kevin about this, but I suspect that he had some of that occurring within the National EMS assessment too. And we're always kind of dealing with that. Why do we find that regionalization is such a complicated topic? I think some of the things that we find to be relatively easy is that you can immediately point to life-threatening conditions, and to a lesser extent, limb-threatening. There are several EBGs that are available to guide clinical treatment, and groups are starting to be a lot more active in publishing benchmarks. So we'll talk a little bit about that. What's a little bit harder for us to wrap our heads around is who has the authority to implement or integrate systems of care. Is it based on patient needs? Is it based on populations, availability of resources, systems finance? And obviously there's a lot of market-based competition in regards to specialty care centers. So that's been a little bit tricky for states to manage. I think anybody that's on the call today is pretty familiar, ought to be familiar with the golden hour concept. What we have found is that while there's a robust understanding of what that means, there's little evidence to directly support the relationship. So as we've tried to embark on our understanding of systems of care, getting that evidence together has really been a bit of a challenge as well. I'm going to focus on the definition that CMS provides in regards to time sensitive, because if you Google that term, you find a lot of different definitions of what it means. From a CMS standpoint, they describe it as the maximum number of minutes that might elapse between a request and the physician's appearance for what constitutes a reasonable response time. Now, obviously, that's not really pertinent to a pre-hospital setting where you don't have a physician on scene. But if you think about that in terms of an EMS response, you could probably make some assumptions based on when treatment, the recognition of the condition and treatment actually begins. The benchmarks that we're all familiar with, you see on the screen now as far as ischemic time and whether folks have interventions are widely publicized. Even see them in the mainstream media from time to time. So those are the easy ones. What happened in the trauma center world, and I know we have several trauma center trauma managers on the call, is that when states started designating specialty centers, there were all kinds of challenges to how the states were doing that, and many states found themselves embroiled in lawsuits about who was recognized and who wasn't. That continues to be an issue today, and I think that it will continue to be an issue for some time to come. Our Specialty Systems of Care Committee tried to put some parameters about what comprised that concept. So if you think in terms of the epidemiology of how things occur within a state, whether EMS frequently encounters and transports those conditions, whether there's model clinical guidelines that are available, what standards of care have been promulgated by an accreditation process or a national organization, and I'll talk a little bit about those in just a few minutes. Whether or not facility inspections are conducted for compliance to standards. And I'm going to pause there for a second because I want to put a plug in for a great presentation that we're anticipating tomorrow that I think we've come to recognize as a growing problem for states in conducting remote inspections and surveys. So if that isn't on your calendar, we have a series of panelists that will help address what they've been doing in their states in response to COVID-19 and their abilities to have physical interactions with specialty centers. And then finally, whether or not there's a focused data collection or a state registry with regards to the condition, so some sort of analysis can be made. What we found out that was very reassuring to us, that efforts to improve cardiovascular care is occurring in all 50 states and DC. It just happens to be happening at varying levels. That formal systems of care coordination is occurring in 82% of states, but as I mentioned a little bit earlier, not all systems of care coordination is directed by the state lead agency for EMS, and we'll explain that a little bit in just a second. The state level coordination occurs most frequently for stroke and STEMI. I doubt that that's a surprise for anyone that's on the call today. Less common is burns, critical care, sepsis, perinatal, pediatrics, freestanding EDs, and reimplantation, although we are starting to see greater efforts in regards to sepsis and some of the pediatric specialties. So I think that you'll be hearing more and more about that. Obviously, burns is a little bit complex. Many states integrate that within the trauma system, so but some states don't really designate those at all. Here was something that was an incidental finding that I don't think really surprised us, but was very enlightening, that whether or not a state has formal efforts in coordinating designation is dependent on whether or not there's authorizing legislation for them to be able to do so. So you'll see pretty much an inverse proportion of those states that have authorizing legislation and ones that don't have any coordination activity based on whether they have the regulatory authority to do so. As far as stroke is concerned, again, no surprises here. The Joint Commission is probably the most robust entity in the US as far as accreditation standards and stroke is concerned. Obviously, the American Heart Association is a close second, and then there's a smattering of other opportunities that you see listed there. Again, all this detail is available in the Specialty Systems of Care report, and we're happy to provide any slides or things that you might need to support briefings in the future. Kevin sort of alluded to this too. We had a problem with the nomenclature from the very beginning of my activities related to NASEMSO, when we talked about a variety of different personnel levels. That's still happening with regards to recognition of specialty centers. So the most common really are described by the accreditation agencies. The Joint Commission and the American Heart Association use those most common terminology. Some states have chosen to stick with that, but there's also a variety of other levels that are being recognized in the states that you can see reflected on the right-hand side of your screen there. What I don't have really good information about is how those other levels are designated and what standards are being used to define those. The best information is really related to the comprehensive and primary stroke centers. So this might be a little bit hard to read on the screen, but we do have some graphics available in the report that shows you the states that are that have designation criteria and/or national accreditation. Some states, the ones that you see especially reflected in yellow there, have a hybrid system where they may rely on a combination of information from the Heart Association or Joint Commission, and some that were determined internally within the states. The availability of registries is pretty well established, with three main registries being available to support stroke care. The Get With the Guidelines is obviously a very robust presence in the states. Some states are developing their own registries, and you see that there's 30% of states that use the Coverdell registry that's available from the CDC. There's actually 9 states that currently participate in the Coverdell program. We were unable to get a response from one of them, and again, it was probably related to the fact that the system coordinators are not located within the EMS office, and reaching those folks is a little bit challenging. I know that NEMSAC has focused on this particular topic for a period of time, and again, something that I think probably deserves a little bit of discussion, maybe not today, but what stroke assessment tools are being used across the country in a pre-hospital setting. The ones that were most common are currently listed in the NEMSIS data collection tool, and you see there that the Cincinnati Stroke Triage Assessment Tool and FAST are commonly used by EMS agencies. Some of the other ones that were reported to us by the states, you see on the list there, to a lesser frequency, and the Boston Stroke Scale, which is apparently available as an option in NEMSIS, isn't being used by any of our respondents. So we'll take just a second to talk a little bit about the data that we found with regards to STEMI. Again, we tried to establish what terminology and nomenclature folks were using to designate cardiac centers, and again, kind of a smattering of titles there. The most common ones, in a way that was similar to the stroke centers, are determined by the main participants: chest pain centers with primary PCI, chest pain centers with primary PCI, and resuscitation were the main ones, with a variety of other levels that states have decided to recognize. Again, we don't really have any great information about what standards are being used in that regard, except that there is a level of coordination in the states with regards to STEMI care. Similar to the chart that you saw related to stroke, the American Heart Association actually in this situation is the most frequently used among states for accreditation standards. The Joint Commission is a close second, but you see that there are some states that have their own standards and criteria for cardiac care recognition. Whether that's occurring as a result of some state advisory committees or how that's happening, we don't really have a lot of great data in that regard, and did not really delve into that area. As far as cardiac registries, there are several that folks are able to participate in. CARES is the one that is most common in the states. In those areas that have not, that may not be participating in CARES, there's a number of state-developed registries, and that area continues to evolve today. As far as data sharing is concerned, there's a plethora of registries available out there. Whether there needs to be a single standard, I don't think that I really need to comment on that for this audience. Really depends on what the demand that you get from your facilities and institutions and constituents, so to speak, as far as what things you want to participate in. On the trauma side, we know that there's some expense related to submitting and pulling data from the National Trauma Database, and I think that there's a cost factor with regards to the cardiac registries, although I don't have firsthand information in that. there's so many different agencies involved in sharing information that some challenges may exist with establishing and maintaining accurate registries that include EMS encounters. We were able to establish that stroke and STEMI are identified in the emergency medicine literature as time-sensitive conditions. I did in the report that we listed a variety of resources. We've made them available on your screen today if you want to download those and refer to them. The problem that seems to be occurring is that a lot of the program coordination is happening in the chronic disease prevention bureaus or offices within the state health department. They're not located in EMS offices in general. And because of that, there's a general lack of funding and resources to EMS to improve care, even though we are defining these things as time-sensitive conditions. That concludes my information snapshot about specialty systems of care, and I'm happy to answer any questions. I don't know if we have any hands raised there. I'm sure Kevin remains available, or if anyone, we can open microphones if anyone would like to make comments. We just really appreciate your kind participation today. Dia?
Thank you, Kathy. Hopefully everyone on the line heard about something or learned something new from these recently concluded or in progress projects that we've covered for you. We do have a manageable enough audience size that we can turn the unmute all on and try a grand experiment here. We would ask that all of you manually mute your computer or your telephone, but we certainly would love to have some interaction here with either questions or comments, whatever's in order. And Kathy, if
I just, yep. Not really having, we've tried to unmute all microphones. I don't know if we got folks there.
This is Brett Hart in Texas for a question for Kevin.
We heard you, Brett. Give Kevin a second to get his microphone unmuted. Good to see you on the call today, Brett. We haven't been able to have any in-face interactions, but it's always good to have you participate in the discussions.
Thank you. Kevin, did you say that on a national assessment that's going to come out, you're going to give out or someone's going to donate iPads again, or was that just what we had last time?
Thank you. Hi, Brett. Sorry, I was muted by the overhead, by the god of muting. No, that was when it was a novelty. It was given out the last time. It's not. They're so abundant out there that really wouldn't be meaningful anymore. Good question, though.
other questions, comments, feel free, jump in.
Kevin, Dia, Kathy, this is Dylan from Pennsylvania. I think by the resounding silence that you hear, you guys have done a fantastic job in shepherding through all these various projects and keeping us up to date along the way. I think there's been some really worthwhile work that's been done this year. And I'm certainly happy to have been a part of so many of the different initiatives. And I think that's just a testament to NASEMSO's great staff and to the members that make it up. And here's to a fun-filled 2021.
Thanks for your comments, Dylan. We really appreciate that. I just want to acknowledge that we're all aware that folks are getting survey fatigue, and we try to stagger those in a way so that you aren't getting slammed with a whole bunch of requests for information at one time. It was a little bit challenging this year to be able to collect any kind of data with we know that many of our members got deployed to pandemic response and weren't able to be as attentive as they normally would be. So in the past, when you've participated, and in the future when we know that you'll be able to participate again, I don't think we can express enough gratitude for that, because that's the true strength of the organization. So thanks for those comments, Dylan.
Yeah, Dylan, and appreciate your eternal optimism about 2021.
You know, it's either despair or fake optimism. Take your pick.
Other questions or comments? And remember, you may have muted yourself.
We actually had I've had a couple text messages, so just to respond to some of the questions. We actually had 112 folks participating live in the opening session, so thanks to all of you for joining in. We do know that you know, we've been keeping these lines open throughout the day, basically because you would have had multiple, to have you register separately for each individual session, you would have just had a crazy amount of email traffic in that regard. So we'll be doing the same for the 3 o'clock presentation, which is FirstNet. Again, I've seen a preview of that, and it's very informative. I don't think that you're going to want to miss that. So if there aren't any other questions or comments, you're free to go, but we certainly hope that you can come back at 3 o'clock and listen to a great presentation by FirstNet, our exclusive sponsor for the week, and we are very grateful to them. I see something in the chat box there. Go ahead.
No, that's I was just going to point out the chat box question.
Thank you. Will the slides be posted to the website later today? We can certainly make those available to folks. And we'll put them on. We've had a small section for the NASEMSO Reimagined 2020. As we mentioned earlier, all the sessions are being recorded, so those will become available as well. The Surgeon General obviously pre-recorded his message to us. The availability of any federal official at this particular time has been very challenging, but we're grateful to him for sharing his information with us. That'll be available as well. The reports are on the website if you missed them here, but certainly we're hoping to make all this information available to folks, so that it's if you have reports that you need to make to legislators or the public, we can provide any of the information that you want in a PowerPoint format. You don't have to digest the PDF version. Just make sure to let us know. Dia, did you want to mention about the draft resolutions?
I do not. I don't have knowledge of any that are advancing with certainty. We have established a deadline of, I believe it is noon tomorrow. Beth can correct me on that. That if in fact any of your deliberations from council or regional environments yields a resolution like we might have had in person at an annual meeting, there is a mechanism to entertain those during the Thursday annual business meeting. I'm sure we'll leave this line open. I would call this the equivalent of perhaps this session being adjourned, but just like if we were standing in the meeting room or in the hallway at the annual meeting, I and perhaps some of the staff can hang out here and just pipe up if you'd like to ask any additional questions or have any conversation as others depart and get 15 minutes back in their day.
All lines should be unmuted. If you wish to speak up, you may have to unmute your own particular line. But absolutely, deal. We can keep the line open. This is ours for the period.
Hey, Kathy, Dia, and the team, Donnie here. Just wanted to say thank you for all the effort that went into making this happen and ensuring that we had a virtual meeting experience, even though we can't be in person. But just wanted to acknowledge and thank you for that.
You bet,
Thank
Donnie.
you. Yep. If anybody has anything else that they want to talk about, we'll be standing by for the next several minutes.
Kathy, this is Guy Danz in Utah.
Hi, Guy.
I don't know if you can see me, but hi. Anyway, what I was going to say is we have a legislature that approached me last week about creating a new behavioral health emergency response technician, like an EMT, only for behavioral health. Are you aware of any other efforts anywhere that might be doing this already?
Well, it's funny you ask. In fact, we held a conference call with our sister associations like NAEMT and IAFC and NASEMSO and a few others with the Center for Health and Justice, the same one that when I went through the projects, we were talking about, that's for post-opioid overdose. Anyway, the Center for Health and Justice has this cool model of setting up national consortia to identify resources like what you just cited as needs and work on developing them. They're also pretty darn good at getting funding from the Department of Justice. And their theory on this subject is that the law enforcement community that they're immersed in wants to get out of the business of being the first responder for mental health emergencies, and would be very amenable to a model emerging to sort of reverse the paradigm and put, if not EMS alone, EMS partnered with a social worker or some other type of clinician as the frontline resource with law enforcement way back in the cold zone, if you will. I do not know of certain, well, I am certain there's no national resource, but we're on the verge of identifying communities where this kind of alternate response paradigm has been implemented. We've been, between us and Health and Justice, we've been sort of collecting anecdotal information about where we've heard about it happening. So I can dig up. It's a limited number of communities, though, Guy. It's one here, one there.
But I think that's what he found. He actually presented the concept to his association for like state legislators, and they didn't have anything that he was aware of.
Right.
We do have a small, limited in the Salt Lake City area, a few clinicians that go out on 911 calls that are for behavioral health issues.
but
Right.
it's so limited because the people that are going out now are master's level individuals. So he wanted to create a very baseline technician level, just go out to the scene, assess them quickly, get them the proper help. And, we had a shooting a few weeks ago in Utah where a kid with autism, the law enforcement responded and he ran at them and he was autistic and he didn't know better and they shot and killed him. Or well, they shot him. I can't remember. Yeah, I think he died. Anyway, I can't remember the outcome. But it was just a horrific deal. And I think it's one of those things, and this is his feeling, was we could prevented those kinds of things. And it's a much better use of the resource we have specifically trained people rather than law enforcement or EMS. But he wanted to put it in our EMS system as another type of responder. So anything you hear, anything that you might be aware of, let me know if you can.
You bet.
And I'll try to let you know how it spins out with our bill and how, where we end up in the long run. So.
Right. One of the things I anticipate is that not unlike EMS, but in the social work community, when you get into rural and frontier counties, you're not going to have a social worker. And
that's right.
We'll have no choice. We'll have no choice but to talk about, EMS personnel at some point. However, I also think that just like when we grappled with the emergence of nurses being, not primary, it was certainly not sole, but being prime personnel in the back of an ambulance, they too needed an orientation, right? They didn't learn everything about the back of an ambulance in nursing school. So I think something similar is going to be needed for the social work community of what if you do need to transport this patient 101 and consideration about the EMS system. So we have our next consortium meeting scheduled for next week sometime. I want to say the 20th. And Steve McCoy was on the last one along with Kyle. But I see us taking off pretty quickly. The law enforcement community is really ready for something else to happen.
Yeah. Honestly, this is a different category of person. It's not the right tool for those type of people.
Right.
And so anyway, let me know if there's anything I can do. I need to bring myself up to speed if there's been any other efforts or where things are nationally. So.
Yeah, no, they're really, and in fact, it was the executive director of the Center for Health and Justice was coming up empty-handed because he thought, somebody has to have figured this out already, in the EMS world. I'm like, no.
Yeah, it's a problem. I know. We definitely have our share of it here in Utah. So, all right. Well, keep me in mind, and if you know anything, let me know. And I really appreciate that.
Yeah, you bet I will.
All right.
Yeah, this is Carol. I wanted to pipe in on that if possible.
Yeah.
It's a different model, but in Ohio, actually at my hospital, as well as if you speak with Dr. Dave Kessick in Columbus, we don't have an actual EMS level, but we do have some regional and local plans where EMS can respond to a psychiatric emergency and transport the patient directly to a facility that either has a social worker on scene. It depends on the funding. Sometimes social workers can go out or rendezvous with them, which I believe they do with Dave Kessick's plan.
Okay.
We don't have that resource, but the facility that my local hospital has a social worker there. So if EMS can get them to that area, it unloads the emergency department. It also puts them in a facility where if they do need to be admitted, they could go directly there. The challenge you are going to have, it's not just an EMS and law enforcement issue. It's also a problem, I won't say a problem, but a hurdle with the psychiatric facilities. When they bring psychiatric patients to the emergency department, they expect us to quote unquote medically clear them before they're admitted to the hospital, make sure there's nothing medical or traumatic or whatever going on. I can tell you 95% of the time we get blood tests and there's no reason to admit them medically. So you have to work with a lot of these facilities, particularly if someone's got a long history of psychiatric illness. You could draw their blood every day. It's going to be the same. So if we can skip that step, it's just really difficult. And you have to put a lot of energy into discussing this with the behavioral health folks and have a psychiatrist that, is not so petrified of getting sued because someone, quote unquote, may have a scrape on their knee or their thyroid functions a little bit off, to accept these patients without going to the ED.
Gotcha. Well, I'm glad
I appreciate that input. Yeah, that
Yeah.
helps me think about that too. Thanks.
And the other thing too, when I hear you talking about a special level at EMT, you still need law enforcement backup. The medications we use to pharmacologically manage patients who are uncooperative or get agitated or psychotic are very valuable. They prevent deaths from exhaustive excited delirium, exhaustive mania, etc. But it also protects the EMS providers and everybody on scene from getting hurt. Mm-hmm. And unfortunately, a lot of these medications are not within the scope of practice for an EMT.
Mm-hmm.
Hey, Dia.
Yeah.
This is Kevin. So just a little bit more on that same subject. Wake County EMS in North Carolina has had for several years now, they were the first one that I'm aware of in the nation, a intervention protocol for behavioral health emergencies. And they have a very specific protocol in place, well used, well benchmarked, in cooperation with their faith-based behavioral intervention facilities in that area, so that when their version of a community paramedic is brought in a 911 situation, or it's just a paramedic crew, they have a very specific protocol for medically clearing the patient before, while they're connecting with the faith-based referral centers, and then transporting the patient to one of those centers rather than the ED. That model has been replicated elsewhere in at least a couple of community paramedic programs I'm aware of in Texas. And I don't recall in Texas whether there are any special, whether the community paramedics actually handle the intervention or whether they pair with a social worker and a cop or not. But I know there are blends all around the country of those kinds of teams. So.
Thank you.
And in Columbus, they actually have one. They they used a closed hospital that they opened up for directly to take folks with opioid addiction. And get the naloxone in. They wake up. They're awake. They go. It's a medical facility, so they could take them directly to rehab instead of following them through the emergency department.
Hey, this is Guy in Utah again. Thanks, guys. Are there any protocols or things that you might be able to share with us here in Utah?
This is Kevin again, Guy. I definitely know that Wake County will share everything they've got. You might just go online for that, but the contact there that I would use at this point is John Olson, who's the deputy chief.
Hold on, let me write that down. I'm grabbing my pen and notepads. What was the person?
His name is John Olson, JONOLSON. I will get you his information momentarily.
Cool. Just put it like maybe in the chat or something.
Yeah, I'll do that. Okay.
Thanks.
You bet.
Happy to talk about anything else. If I know some people may have just left their screen idle and walked away, but I'm certainly free to hang out for a few more minutes.
Yeah, I did get a note from Beth to remind folks that the official business meeting is on Thursday, and that if there are state directors that want to appoint a proxy, they should email her.
Oh, yeah, let's do can we do that as an announcement at the beginning of the next two sessions?
Absolutely.
Awesome. Thank you.